And so without further ado, you go for the first presentation. And so duodenal jejunal bypass liner treatment for type 2 diabetes and obesity. I'll have the pleasure to, please, you can start now.
Thank you very much. So I'm talking about the duodenal jejunal bypass liner. These are my disclosures. And this is a duodenal jejunal bypass liner. It's also known as EndoBarrier or Reset. And as it's been most widely known as EndoBarrier, I'm going to call it that for this presentation. It's a 60 centimeter impermeable sleeve implanted during a simple endoscopy procedure into the first part of the small intestine, such the food passes through it rather than the small intestine, and it mimics the bypass bit of the Romaine bariatric procedure. And many studies over many years have demonstrated that it results in a considerable amount of weight loss and improvement in glycemic control while it's left in before being removed in an endoscopy procedure after up to 1 year. In view of the uncertainty about the risk versus benefits of EndoBarrier, during 2017 an independent secure online registry was established under the auspices of the Association of British Clinical Diabetologists for the collection of safety and efficacy data of EndoBarrier treated patients worldwide. The outcomes from the registry were published last year in Diabetes Care, for the purpose of this presentation, we're considering that many of the serious adverse events associated with EndoBarrier occur during the last 3 months of treatment. Reducing the period of implantation to 9 months may reduce the complication rate. We aim to assess safety and efficacy of 9 months versus 12 months implantation using data from the registry. As of March of this year, data have been entered on 1,101 EndoBarrier treated patients, of whom 238 had both 9 and 12 months of data entered. And the rest of this presentation is about those 238 patients. You can see their baseline BMI, it was a mean of 40, so very obese people. And this is what happened during the EndoBarrier treatment, and you can see that by 9 months, they lost over 12 kilograms weight, and by leaving the EndoBarrier in for another 3 months, there was only a further 1 kilogram of weight loss. And you can see by the 9 months, the fall in hemoglobin A1C of 16 had already occurred, and after that there was no significant increase in the fall in hemoglobin A1C. We looked at the fall in hemoglobin A1C according to baseline hemoglobin A1C, and you can see that the higher the hemoglobin A1C, the greater the fall, such that by a hemoglobin A1C greater than 97 millimoles per mole, the fall was over 40 millimoles per mole. There was no difference between 9 months and 12 months. So the question is, how many serious adverse events would be avoided by reducing the implant time to 9 months? Well, in the full registry, there were 47 or 4.3% experienced serious adverse events. All the SAE patients made a full recovery, and most experienced benefits despite the SAE. However, a third of them would have been avoided by removal at 9 months, and that was 9 liver abscesses, 5 GI bleeds, and 1 cholecystitis. And it was particularly noteworthy that over 60% of the liver abscess SAEs would have been avoided by removal at 9 months. And this is that data in another form. You can see a third of the SAEs occurred after 9 months, and 9 of the 14 liver abscess SAEs occurred after 9 months. I'm just going to share some of my EndoBarrier treated patients with you, so you can see the dramatic improvement in this patient's central obesity, but most of it had occurred by 9 months with a big improvement in his diabetes. This lady with ALT reflecting fatty liver as well as poor glycemic control, she in fact by 12 months had gone from obese BMI to normal BMI, and her evidence of fatty liver had disappeared, but this had already occurred by 9 months. This lady, as well as having obesity with quite a lot of insulin, had obstructive sleep apnea requiring continuous positive airway ventilation at night, and she was delighted that, as well as a big reduction in the dose of insulin and improvements in glycemic control, she no longer required the continuous continuous positive airway pressure ventilation, and she was very pleased about that. This lady, as well as the improvement in diabetes and reduction in insulin dose, had an improvement in her renal function, and that had already occurred by 9 months. And finally, this lady here went from morbid obesity to normal BMI, a massive reduction in the requirement for insulin, but most of the improvement had occurred by 9 months. And this lady had presented at 11.2 months, basically with a liver abscess requiring intravenous antibiotics and urgent endobarrier removal, and this serious situation would have been avoided by removal at 9 months. So in summary, in conclusion, the effectiveness of endobarrier at reducing weight and hemoglobin A1C is again confirmed. The higher the baseline hemoglobin A1C, the greater the fall, with a fall of over 40 millimoles per mole if the baseline is greater than 97. Little significant difference in the weight loss or improvement in hemoglobin A1C between 9 months and 12 months, but a third reduction in SAEs and over 60% of liver abscesses. These data support a change in the recommended implantation period for endobarrier from 12 months to 9 months, and as endoscopy units are ubiquitous, delivery of endobarrier treatments could be relatively straightforward.
Thank you. So we'll have time for a couple of questions. I urge you to make it really small questions, short questions, please.
Thank you. Question is, after 9 months, if you remove it, what happened? Any follow-up?
Well, in our experience, we found that 3 years after the endobarrier removal, 77% of patients maintained the improvement, with only 23% going back to baseline. So with support every 3 months as needed, we were able to help them to keep the weight and hemoglobin A1C improvement.
Did you see any improvement in other parameters such as lipids and proteinuria?
I have to say we didn't look at particularly either of those, though we did see, we saw an improvement in cholesterol and blood pressure and UK PDS cardiovascular risk assessment.
Do you have the results? Because we've presented 9 to 12. Why not 6 to 9 to 12? Because when we have the diets and everything, most of the effect will be in the first month.
Maybe I'll be presenting that this time next year.
Okay, thank you. I think congratulations. We move for the second presentation.